I'm Peggy Peck, MedPage Today, and it's day 2 in San Antonio at the American Stroke Association's International Stroke Conference. Today, great deal of data dealing with new ways to treat acute ischemic stroke. And I'm here talking with Dr. Cheryl Bushnell from Wake Forest University to discuss some of the papers reported this morning. It's interesting to me because we're talking about a number of different approaches toward the same goal, and that goal being extending the treatment window, more effective treatment, and obviously patient benefit. So let's start at the top end, different ways to deliver TPA.
So we heard about the fact that there were multiple ways to open up arteries. There's putting a stent in, opening up an artery with angioplasty and then inserting a stent. We heard about intra-arterial thrombolytics. There are other antithrombotic therapies that are given intravenously, and then there are devices like the corkscrew Mercy device that can open up. And then there are also devices that will basically use a jet type of mechanical way of sucking the clot out rather than using a corkscrew. So all of those devices are all FDA approved to open up a blood vessel. And the one study from multiple stroke centers with people who do interventions showed that in terms of just opening up a vessel, recanalization as the outcome, that angioplasty and stenting is probably the most effective. Now that just doesn't mean anything in terms of actual outcome, but recanalization is an intermediate step and is associated with better outcome. So the assumption is that people who have that procedure will have better outcome.
But there's an issue of patient selection there about what patients would be eligible for that procedure.
Exactly, very careful patient selection. So I think the bottom line is that the therapy probably does work, but it's operator dependent. There's a lot of skill involved in learning how to do this. They have to do multiple patients, and so it basically you bias towards the centers who do it, and they are the ones who are reporting all of the data. And the important thing about that particular study is that it's not a randomized controlled trial. It's a retrospective database analysis of these centers that have the skilled interventionalists who are doing these different procedures to open up arteries. And I guess in terms of that, that's homogeneous, in terms of the sites that they're using, and but the difference is careful selection of patients, and of that situation in that particular setting, it appears that the angioplasty and stenting is probably the best in terms of opening up the artery.
Now, in terms of this careful selection of patients, one thing that we've heard about today, and we've been hearing more about in recent years, is that there may be more to patient selection than simply a time window, which of course we've the 3-hour window and then extending it to 4.5 and perhaps 6 hours. But another issue may be that a better way to determine, for example, who might be eligible for thrombolysis might be using an imaging technology, DWI, and that might give us the kind of solid information to decide what patients would or would not benefit from which intervention.
Right.
Tell us a little bit about what we heard about that today.
Well, and this was again, a retrospective look back, but what it does show is that if you do select patients with either MRI or CT perfusion, which shows you what part of the brain is at risk around the stroke, then those patients may benefit even if it's after the 4.5-hour window. And so in that situation, a lot of centers will actually use intra-arterial TPA in that situation because I think the risk of bleeding is lower. But in general, they are able to safely use these other techniques in patients who are beyond the window if they're carefully selected based on imaging criteria. So it's important for that reason, and in practice, that is kind of what happens. Every patient, individual stroke patient, is a little bit different. And I think the heterogeneity of stroke in general it really is a challenge for stroke research and improving treatment, because no one size fits all.
Now, a third area of research that we heard about today, and this one has always really intrigued me, is this induced hypothermia. And they've looked at this in many areas of ischemia, and they found some success with it, certainly in coronary ischemia and whole body ischemia. But it seems to have been difficult to see real progress when we talk about cerebrovascular events. And so this was an interesting approach today. It was endovascular induced hypothermia.
Right.
And it was combined with TPA. I'm wondering if you can talk a bit about that.
Yeah, so the hypothermia used to be just surface cooling, just putting cold blankets on people. And as Dr. Hemmond said, the skin is very sensitive and people shiver and they have to be paralyzed and intubated, and you can't really follow their neurologic status for that reason. So that was a major limitation for the studies on hypothermia. Now that there's endovascular cooling with basically a central line, which is not uncommon in patients in the ICU, a central line delivering cold saline and using heating blankets on the body to basically fool the skin into thinking that it's warm and generally not noticing the cold core. But that delivers cold blood to the, cold blood to the brain, which is where you want it to be. And so what this is kind of a concept of neuroprotection. It slows down metabolism, and it slows down all of the toxic chemicals that are released in the acute stroke setting, in addition to opening up blood vessels. So the concept of reperfusion plus neuroprotection has been bantered about for a long time, but this is perhaps the first combination that might be actually successful. And it was mainly a feasibility safety type of study at first, but they're moving forward with that.
I think we have to say that it really did not show a benefit, and in fact, it did show that there was a pretty significant rate of pneumonia in the patients the small group of patients that underwent the hypothermia. But they did say that they're moving ahead with a phase 2 trial with, I believe, 400 patients. So altogether, a group of interesting studies with suggesting that we are making some steps forward in acute stroke treatment,
Absolutely.
which has really been a difficult therapeutic challenge.
Yes, it has. Yeah, I think it's very exciting. And it's, the devices and different things to open up arteries is going to continue to be developed, but ultimately what we want is to see patients get better.
And perhaps to prevent stroke.
And my passion is prevention, but yes, absolutely.
I want to thank you very much, Dr. Bushnell. In San Antonio at the American Stroke Association International Stroke Conference, I'm Peggy Peck for InFocus.